medicine. All right, who are our patients and what do we treat? So complex comorbid medical and psychiatric conditions. So you can think, all sorts of patients. The way I like to say it is psychiatric patients get medically ill, get critically ill too, and oftentimes will come into the hospital and, like I mentioned before, medications will be stopped, or there's a lack of understanding or misunderstanding about the nature of psychiatric conditions. And so we absolutely get involved and can make a huge difference in the trajectory of a patient's course. And the complex psychopharmacology can also be really challenging and is not is a reason for consult that isn't at all infrequent. We also have to consider that inpatient psychiatry units can't take every patient, so often because of medical concerns. Medical psychiatric units as a combined unit, med psych units, are pretty uncommon. And so if a patient requires IVs, transfusions, dialysis, other medical equipment, if there just aren't psychiatric beds available, patient may need pretty intensive psychiatric treatment while they're on the medical service. And so we're absolutely there and frankly, sometimes function almost like a primary team when a patient is medically cleared awaiting transfer, or if for whatever reason they can never be transferred. So you really get that component of it too in the inpatient consult context. We also have disorders that are secondary to medical treatments. All the time I'll get calls, especially in my role as with the neurology services, where somebody will be on Keppra and maybe has a higher level of irritability, and we can recommend transitioning to something like valproic acid if it's clinically appropriate. Or we will have patients who are started on steroids and might have a manic episode or may have increased irritability, and problem solving around that can be really helpful in conjunction with the medical teams. Just a list of some common consults. You may have seen plenty of psychiatry consults already, but if you haven't, delirium and agitation, capacity, those three are probably just some of the most common ones on a daily basis. I'm thinking about those kinds of things, how we can manage that from a psychiatric standpoint, if in fact there's a psychiatric etiology to the delirium, agitation, or reason that someone may lack capacity. And then, a range of psychiatric complaints that you see in both inpatient and outpatient settings. We also get vague consults sometimes for things like psychiatric history, or maybe this patient needs inpatient psychiatry. And it can be both fun and frustrating to get these vague consults, because you call back and you just never know what you're going to get. It may be that the primary team has something else completely going on and they just need your help. And so it's very fulfilling to be able to be there for them, regardless of what the reason ends up being. There are a lot of areas of subspecialization within consult psychiatry, everything from HIV psychiatry and reproductive psychiatry, which there will be a talk on later, I believe, psycho-oncology, transplant psychiatry, and then I added neuropsychiatry and critical care psychiatry for my own interests. But these are pretty well developed as subspecialties in the field. Some of them, even particularly reproductive psychiatry, have their own fellowship programs, but exists within this broad umbrella of consult liaison psychiatry. Other things to mention about who our patients are: we're often called in cases of inpatient psychiatric emergency, things like catatonia, serotonin syndrome, and NMS, things like eating disorders, neuropsychiatric conditions with behavioral, mood, and cognitive overlap, Parkinson's, multiple sclerosis. Those are the ones that I commonly may be consulted on. Just to highlight eating disorders, I have found that some of the most challenging patients that I've treated in the general hospital have been patients with eating disorders, because in a way the treatment is really an outpatient course, very intensive, often very behaviorally focused. But if you have somebody who's unstable from a medical standpoint, you get into all kinds of challenging legal and ethical issues about treatment over objection, NG tubes, TPN, whether or not somebody's going to need an ICU stay, developing behavioral plans, in cases where there's comorbid personality disorder as well as eating disorder, making really clear boundaries and really helping to support the primary team who may become burned out if a patient is really suffering and over this long period of time just a particular area of challenge, but also an area of opportunity and interest, I think, that's overlooked often. And then beyond just patients, this is working with team dynamics, transference, and countertransference that I mentioned before. Now I keep highlighting this liaison aspect, but it's because it's so unique to the specialty and because I find it so fulfilling. Yeah. So also things to consider, addiction consults. So there's a whole area of psychiatry, a subspecialty that's, you can get your board certification, addiction psychiatry, but we are very frequently contacted for complex withdrawal syndromes. And some hospitals that have large consult services may have a psychiatrist dedicated to addiction consults. More often than not, however, it's on a consult liaison psychiatrist to help manage in those complex cases. Pediatric and geriatric patients. So somebody who might do a child and adolescent fellowship may then do child and adolescent consults in a pediatrics center, both inpatient or outpatient. And then geriatric psychiatry, again, a whole separate subspecialty, but many of the patients, the majority of patients that we get consults for are of an age to be within the geriatric spectrum. And all of the considerations that go along with that, with dosing and special considerations for social support and what it might mean if someone has had a devastating illness and is going to need to go to rehab, subacute rehab, acute rehab, or long-term care. So processing, not going home. Then the legal aspects of consultation, I also had in mind forensics here. I've spent several days worth of court cases in front of a judge testifying on behalf of the psychiatry's position with treatment over objection cases in particular. Thinking about that in great detail, there are a lot of challenges, particularly with ethics, risk management, social work is often involved. So these really large, wide interdisciplinary teams that you work with. And oftentimes you find yourself coordinating care and really managing quite a large scope. I would also note that with the turnover in teaching hospitals, where the medical students may be rotating every few weeks, the residents, the fellows, the attendings may be rotating, the consultant psychiatrist and some of the other consultants may end up being one of the greatest points of longitudinal care that a patient gets while they're in the hospital. And so maintaining that vision can sometimes be extremely helpful to the care of the patient, and kind of making yourself available and getting involved in that way can make a huge difference to that trajectory, and that can be a very fulfilling part of the job. So how does it work? So for the inpatient consults, I'm highlighting the inpatient just because that's the majority of what I do and the majority of what people think of for consult liaison psychiatry. I think as we go into the future, there are a lot of opportunities in the outpatient space, but perhaps not fully realized yet. So is your pager beeping? You can think of the consultant who's out on the wards and they get this pager, a page or a message on, Epic, like Epic Haiku or something. You get this message, this one-liner, can you please call me about this patient? And determining whether or not the consult is appropriate, talking to the primary team. I mean, these are all parts of those of that skill set. So you get the consult, you clarify the consult question, you do chart reviews, you check the emergency department course, you see what all of the medical problems are, you're looking over labs and medications. On a daily basis, I'm looking at have they gotten PRNs, what are they on standing? And particularly when somebody has a lot of transitions of care, looking at that in a comprehensive way, with that the eye of a psychiatrist, you notice all sorts of things like stacked PRNs, or somebody's gotten 4 types of benzos in the last 3 days. You notice these things and can really help manage that aspect of care. So you have your initial and then the follow-up consults where you may be following for bedside psychotherapy if it's appropriate for a patient, if you have the time for that. And then as new questions arise, perhaps you have a patient who first you're consulted for withdrawal, and then the patient has some medical complication and you're managing an agitated delirium, and then you get another call for capacity to leave AMA. And so you're getting all kinds of questions with the same patient. So understanding exactly what's going on through a course of care, and then even more longitudinally as people are readmitted and you may meet the same patient again. A lot to keep in mind. Also the importance of collateral. Particularly in community psychiatry settings, you may have a patient who is acutely decompensated and no one knows who they are, and helping to manage the aspects of their psychiatric care. At the same time, there's a search for someone's identity, and understanding that greater context can be extremely difficult. You get just the right person for that collateral, and you can really change the whole course of treatment. This is true across psychiatry broadly, but I think particularly in the consult setting, it's something that primary teams don't always have the time and opportunity to focus on, and it can really change the direction that things go, just to really emphasize the importance of that. You also have all kinds of opportunities for bedside psychotherapy skills. I think of any time that you meet a patient, you have an opportunity to interact in a way that reflects a particular style of psychotherapy, even if it's just brief, even if it's just supportive. And you can run across all kinds of things that are challenging for a patient or that may benefit their course of care in doing that therapy. I always think as I'm going into a room, all these little details that you notice, the smell of the place, where the food is, how much is eaten, what it smells like, are they by a window, who's sitting at bedside, is it an ICU or step down, how loud is it in there? All of these things can make a difference, particularly when I'm thinking about the number of delirium consults that we have, and you have a patient who's in the noisiest, darkest room on the unit, and advocating for them a little bit can make a big difference. And then again, talking to the primary team, I mean, you're right there. I find myself daily going to workrooms and catching people in the halls. That's one fun thing about being somewhere long-term too, after you're done with all of your training and you have a chance to form these relationships with your colleagues across departments. You get to know each other on an interpersonal level. The way you ask questions, the way you have conversations is so different, and in a way that really benefits patient care. So in consult psychiatry, you absolutely have the opportunity to do that beyond your own department and expand that circle within a greater hospital context. I think it's no accident that you often find consult psychiatrists working in medical student teaching and administration, both in a department and education context, just so within psychiatry, and in schools medicine and more broadly, because you are working cross-disciplinary so much. So how do you decide on this specialty and when? Rotate on CL early and often. So medical student, the medical school clerkship, of course, you may not have as much choice with where your clerkship will be. Many of you have probably already completed your clerkships. And then the VSAS and away rotations is another opportunity. So that was one of the more fulfilling opportunities I had in medical school. Was I did a visiting rotation, the sub-I that I mentioned before, very different location geographically from where I was based in medical school. I got to see a really different way of practicing psychiatry, practicing consult psychiatry in particular. No two institutions do it exactly the same way. And the more exposures to those services that you get, the better you are for it. I think, especially if you end up going into consult psychiatry, you have notions of like running a service or something one day, which many consult psychiatrists do because services typically are quite small. That perspective that you get is invaluable. The application cycle for fellowship begins just after the PGY3 year. So that's when, so you're in psychiatry, you're doing your core rotations within your psychiatry residency, which will inevitably include a consult rotation. And so you get to the end of your third year, And that's the time to have those conversations with mentors and people who know you well about whether or not this is a specialty that is right for you. If you have that interest, I could say for myself, I considered doing a geriatric psychiatry fellowship or a neuropsychiatry fellowship around that same time, and helping to clarify those career goals. I knew I wanted to be in academia. I knew I wanted to be teaching residents, medical students. Really identifying those goals can be helpful in making that decision. Like I mentioned before, it's one of the 5 ACGME accredited fellowships. I found it to be more broad than geriatric psychiatry, and I liked that it was ACGME accredited just for the sort of academic credential and cachet that carries. If you wanted to run a program one day, that's something that would be necessary. So that's the time that you would really need to make the decision about whether or not to apply. And then, of course, the path through the interviews and the applications gives you more of an opportunity to really take a look at whether or not it would be right for you. It's much less competitive than anything you will have applied for ever previous to that. So you have a lot more choice in the matter. And I'll show you a couple numbers from a presentation. I want to say it was a presentation from last year related to applying to fellowships. The last thing is join the ACLP, this Academy of Consult Liaison Psychiatry. I have another page on this to really emphasize the point. There's so many opportunities for mentorship, scholarship, networking, conferences and committees, and it's all a free membership for medical students. I think they just have to verify that you're a medical student. But they have such a rich website. I think it's one of the first things I go to, even within other areas of psychiatry. I just feel like they have so many already prepared PowerPoint presentations on all of these topics that you'll learn about in residency. So it can be really helpful. Or if you're ever asked to give a short talk on something, they may have the pretty nice, recently updated presentation within that website. And you have access to all of these materials free with membership too. There's also a journal, the Consult Liaison Psychiatry Journal, previously called Psychosomatics. And then I'm trying to think of other things that would be there that would be of interest. I'll show you the headings though in a moment. I'm part of the medical education subcommittee for the organization, and we're working on having a site that would be specifically for medical students. So you can keep an eye out for that within the next year. And the other thing is we'll be including a medical student most likely within the next year on our committee. And in order to be selected for that position, you would need to be a member. So many reasons to potentially become involved if this is something that you think you might be interested in. Why do a fellowship? So some of the things I've already mentioned, but essentially developing expertise in the specific populations that are served. The extent of your CL training and residency varied. So I found that the type of CL training that I had in residency differed from what I experienced in fellowship simply by the type of institution and the type of hospitals that were part of that training. Fellowships have a different division of inpatient and outpatient components of their of the 1 year that you're there, and may be located at one site or multiple sites. I think there are several that have a combination of a VA, an academic hospital, and a community hospital, for example. Others may have one site, but you'll be doing a higher amount of outpatient CL work. So if you're interested in ultimately having primarily an outpatient practice, maybe moonlighting as an inpatient CL attending or on weekends or a couple days a week affiliated with a hospital, this is something that you would take into consideration at the fellowship application level. On the residency level, if you think this might be a fellowship that you're interested in one day, you can look for places that emphasize those skills, the liaison skills, the types of psychotherapy that you would do at bedside, and having really good medicine training, I think, makes a difference. There are, of course, combined programs in internal medicine and psychiatry. I found anecdotally that colleagues who have been part of those programs have tended not to go into CL roles, or at least not to do a CL fellowship. Granted, that's an awful lot of training, but have tended to operate in a CL space anyway, and still are often found at our consult liaison meetings. Same is true for folks who do dual training in psychiatry and neurology. So you also, like I mentioned, opportunity for exposure to a new institution, deepen, expand relationships professionally at an institution where you may do your residency. If you're thinking of going on faculty somewhere, this is a great chance to still have that level of supervision, but be able to explore in great depth this patient population. And if you have a particular area in mind that you'd really like to deepen your expertise, usually fellowship programs are quite flexible in doing that. Right, and it can be so much fun. I had so much fun in fellowship. I thought it was just, the colleagues, the professional development, the lectures that I got, I really enjoyed it. And I think if you like some of the things that I've talked about, you probably would too. So our CL fellowship's popular. I mean, this is a whole lot of numbers in a chart, but you basically see that there are way more positions than there are applicants in a given year. About 70% of the positions that are available fill. And most people end up getting their first or second choice of fellowship. So this, I think, is perhaps very reassuring. And then the number of fellowship programs has continued to increase over time. So take that for what you will. It's at least, I realize that it's a number of years off for most of you, but something to at least have in mind. Just to reemphasize the point of the Academy of Consultation Liaison Psychiatry, there's a link right on their page, and that is join the ACLP, and it's pretty straightforward. And like I said, lots of great resources there. Let's see. Oh, I also wanted to just highlight this. So CL Psychiatry and COVID-19. So we have had a very significant role on our services in, and you may have seen at your own institutions in this area. This could be a whole talk in and of itself. There are also the acute and chronic neuropsychiatric symptoms of COVID-19. You'll see the post-acute symptoms of COVID is a priority of the NIMH. It's been highlighted in the media. CL psychiatrists sort of on the front lines of these questions and these issues with post-COVID depression, psychosis, anxiety, suicide. And then just in the broader context of the population at large, having this adoption of virtual consultation models and expansion of care to underserved areas and underserved hospitals. I think that's just been accelerated in the context of the pandemic. And then the level of support to primary teams certainly dramatically increased during this period of time. The sense of hopelessness, physical and emotional exhaustion, people being pulled off of their specialties and into care for COVID patients. I recognize that this primarily happened at the peaks of the waves that we had of COVID-19, but the echoes of this are going to propagate long into the future, certainly through your training in psychiatry residency, and then if you were to do a fellowship. And it would be really interesting to see the PTSD-like symptoms, for example, and just this impact lasting far into the future. I currently have been supervising one of the fellows in our fellowship program in a neuropsychiatric COVID clinic that has been emphasized by the neurology service as well. And we have found that the psychiatric symptom burden is just so high. And there are a lot of publications that are coming out about this recently. So if this is something that is an interest of yours or an area where you have interest in making an impact, I think CL Psychiatry is an excellent vehicle to kind of get to that place. Although broadly speaking, in psychiatry, this is something we'll be dealing with for many years. This is also just a reminder, actually, back on my fellowship slide, probably I would think to mention this. You don't have to do a fellowship to practice within CL Psychiatry because there is such a shortage of CL psychiatrists particularly in areas that aren't magnets for big academic centers. But I think that two parts to this. One is there's great advantage to doing the fellowship, even if you aren't, if you are practicing in these places where it might not be required. But also, if you find yourself interested in these areas, you've been asked to do work with a CL Psychiatry service without the fellowship, and it's something you think you'd like to do, you can always join the Academy of Consultation Liaison Psychiatry sort of beyond that, beyond doing a fellowship, and get those resources, that supervision, and that greater community that can help discuss some of these things. So it's a great place for that. Also compared to the APA, it's such a smaller organization. I think something like 1,000 people maybe went to the conference a few years ago. It's small enough that you really get to know people. It's a really nice community, a lot of fun people. You see the same names coming up. You get to know the people who are writing the papers that you're kind of practicing based on. And I think that's just really it's just a really great community. So I think I'll kind of end off here and then open it for questions. Just the overall message that I'd like to leave you with is that consultation liaison psychiatry is incredibly broad. We treat patients in a number of different settings and with a number of different medical conditions. And if you want to be the psychiatry specialist in a particular disease process, that opportunity is out there. And I think focusing in on that, you really get that both an opportunity for depth and breadth. And yeah, so I hope many of you can be in touch in the future. And if you decide to join the Consult Liaison Psychiatry organization, I'll look forward to meeting you. So let's open it for questions. About anything too. I mean, if you're curious about my ketamine treatment program work or something like that, I'm happy to answer.
So there's a question in the chat. It says, what do you think the role of CL psychiatrists in managing the medical problems in patients with SMI? Yeah,
so that is huge. So this is to that point that I made at one point that is that I think I first became aware of in the ICU when I was an intern, is that patients with SMI become critically ill too. And I became this is one of the reasons that critical care psychiatry is an interest. But you have patients who are on long-acting injectables or who are on high doses of psychiatric medication. They come into the ICU and the primary team stop the medication. And then they stabilize from a critical illness standpoint. And then what next? You have a patient who may be decompensated from a psychiatric standpoint, and you have a much worse outcome than you would have if you had continued the medication. We're increasingly looking at data on outcomes in exactly that kind of context. And so I think CL psychiatrists are critical for making sure that the questions around mental health care are front and center in the minds of the teams that you end up working with. So that's one part of it, and that's specific to critical illness, but not exclusively. Many medical teams will say, oh, we need to stop this because XYZ, and it may or may not be true. So I think that's why it's really nice to be involved there. The other part to say, and this reminds me of some of the work that I did at Bellevue in fellowship, that's a huge community hospital with a legacy of care for the underserved and folks with SMI, and again, medically complex, very difficult to control psychiatric symptoms at times, and thinking in that greater systems view about how we can manage this patient long-term. Oftentimes you are the psychiatrist that they're going to see. You are helping to arrange an ACT team. You are helping to make sure that someone is transferred to an inpatient unit. You may be part of that longitudinal care in a way that few others have the opportunity to be. So those are some of the ways that I think CL psychiatrists can be involved. If by this question you also mean that a CL psychiatrist may, in an outpatient setting, be the be a connection to a medical clinic or, managing other medications. So for example, does a patient need diabetes medication, something like that? I think it's much less likely that a CL psychiatrist is going to be prescribing something like, insulin or a medication for hypertension. But certainly something like metformin for patients who are on a high dose of Zyprexa, those are the kinds of things we might prescribe. But it's a good question. If you have anything follow up from that, hopefully that's helpful. If you have any follow up from that, feel free to let me know. So I see this other question in the chat. So talking about exposure to or the role of CL with patients that have dual diagnosis of physical intellectual disability and mental illness. And again, this is something that you get by virtue of being on the wards as patients are admitted. Oftentimes, I have found that some patients with particular types of intellectual disability or genetic conditions or a whole range of things that may have influence over mood, behavior, and cognition. That's exactly the kind of thing that we're called for in the hospital disproportionately, because primary teams are often like, well, I have no idea what to do. They say that this patient at home has, the following kinds of things in place as sort of safety valves on their illness, and the level of care that they have is much more intense than what they might be offering in an inpatient unit. And so it's a lot of really practical problem solving that has to happen. Yeah, so I think there's plenty of exposure to that. It's not particularly predictable, but in particular types of units or with particular diagnoses, certainly something you could specialize in or focus on through your training that would give you those opportunities. Yeah, so the next question in the chat is mentioning ethical issues involved with treating patients with eating disorders and examples in that realm or others of how the bioethics background informs CL practice. Yeah, so I'll first speak to the question of eating disorders and then more broadly just ethics in psychiatry. I think that's one of the reasons I went into psychiatry, is because there's so many ethical questions that come up just across the spectrum. So for eating disorders, the particular patient that comes to mind, well, rather I'll say an amalgamation of several patients with BMIs as low as 9.5, where there's a question of the primary team making the claim that a patient is medically stable and that they were thinking about discharge. And we've also been following the patient and whether or not discharge is safe, or whether a patient has a comorbid psychiatric condition that is somehow impacting their weight. So people come in and they say, well, my weight loss is from my chronic medical condition or from dysphagia or from any of a number of things. Really, oftentimes high levels of denial related to an eating disorder diagnosis. And so the question of treating over objection becomes extremely difficult, because these often are patients who aren't felt to be medically stable because of the high risk of refeeding syndrome, aren't felt to be medically stable to transfer to an eating disorders unit. And so medicine is saying, well, look, we think the risk of refeeding syndrome is really low. We don't want this patient on our service for often lots of reasons. And psychiatry is saying, well, we can't treat this patient because of the medical complexity. And then whether or not you're treating them over objection, then you get into these ethical questions. There have been some famous court cases on whether or not patients with eating disorders, and perhaps you could call them kind of terminal eating disorders, after exhaustive treatments, could make a decision related to their eating disorder and then die, and how that overlaps or doesn't with questions of suicide or euthanasia, or so all of these things can come into play. Other things related to that, whether or not a patient meets criteria for voluntary or involuntary admission. CL psychiatrists and emergency department psychiatrists, which oftentimes are also CL trained, depending on the type of institution, are making these decisions all the time, much more than an outpatient psychiatrist would. And you're really up against all kinds of ethical issues about that. You're taking away people's rights, and you're taking them away because you believe that there can be treatment that would enable them to function in a way to make decisions about their own care again in the future. But it's a big deal to take away somebody's autonomy in that way. I'm not saying something I don't think you already know, but just to really emphasize that point, especially in an era of medicine where we really prioritize autonomy, rightly or wrongly. It's something that's really prioritized in medicine, and we're making those decisions all the time. And often we also are faced with medical teams that are making those decisions who may have some reactions to those decisions related to end-of-life care, for example, when palliative care may or may not be involved already. But withdrawal of care, a lot of ethical issues around withdrawal of care in settings where patients do or do not have surrogate medical decision makers, where there may or may not be treatments that are considered appropriate, who considers them appropriate. Psychiatry is often consulted in all of those settings. And so I think for me, having that background in bioethics has really made those conversations a bit richer for me, and hopefully has been a little bit helpful in communicating to ethics teams who are also inevitably involved. I certainly in the hospital context am really focused on the psychiatric issues, but having what anybody's threshold is for saying, hey, I really think we should get ethics involved, might be close to the top of my mind. Might be able to give a little bit of extra input, but it's something I think is good to think about as you go through your training too. Let's see. So some challenges you may have experienced as a CL psychiatrist collaborating with primary medicine team, and how have you addressed them? So challenges collaborating. Well, I think any individual attending is going to have a perspective on the role of psychiatry. So for example, with my liaison role with neurology, I know that if certain folks are on the team, I'm going to get more consults that may or may not be appropriate, or I might not be getting any consults. And I think, I know that the patients are there, but I don't know why I'm not getting a consult. It bears having a conversation. It's all in the relationship dynamics and perspectives on psychiatry and where and how somebody has trained. And so all of those factors go into play. But specifically, I'm thinking of a patient where there was some disagreement about starting a medication. And it was really interesting to hear the reaction that the team was having to a patient. It's again, these questions of transference and countertransference. And because of where those problems were rooted, we ended up having this big interdisciplinary team meeting and kind of just pulling it all apart, and we're able to come to a much better place with regard to that particular patient's care than where we were before that conversation. I realize that that's not perhaps as specific as you might be interested in, but those relationship dynamics are probably the biggest area where I've come across challenges. Let's see. Differences in training and career trajectories of someone with CL fellowship versus dual and triple residency. Yeah, so the dual and triple residency. So I'm thinking about this from, you could come at it from a couple of perspectives. I wonder if you could clarify exactly which one you mean, because there are the programs that are psychiatry, family medicine, psychiatry, internal medicine, or pediatrics, or something along those lines. And then there are the programs that are adult, child and adolescent, and yeah, like PsychSIGN. Yeah. So I think some of it has to do with what you ultimately are hoping that your role would be. CL Psychiatry is specific to doing these consults, whereas the space that I feel that the dual trained folks end up operating in is often a little more academic, might have a heavier research component. But I think that some of the distinctions are not as clear. I think it just depends on what kind of practice you want to end up having. If you wanted to have an outpatient practice where you were primarily doing medication management for medical conditions and then also able to manage the psychiatric medications, then you want to do a dual program. If you're interested in more of the hospital medicine side or the diagnostic mystery, more complex cases that might be more of a consultation perspective than psychiatry and then consults. I don't have a great answer to this question because I didn't do one of the dual training programs. And again, the folks who I know who have done those programs have ended up in clinical practice that really emphasizes one or the other instead of bridging both as effectively as I think maybe they had envisioned when they set out to do those programs.
Any other questions?
I'll just add one extra plug-in for the ketamine treatment program and the other kinds of treatments that are sort of on the horizon for psychiatry. You may have an opportunity to hear about these in some of the other talks that are part of your conference. But I think that with IV and intranasal and even oral forms of ketamine that are out there and available, we're having this expanded toolbox of treatments, and some of them have historically been rooted in other areas of medicine. So emergency physicians and anesthesiologists are very familiar with these medications. And so I think CL psychiatrists are perfectly placed in thinking through the medical aspect of ketamine, psilocybin, MDMA-assisted psychotherapy for PTSD, all of these kinds of things that have the potential to be approved in the next 3 to 5 years as you go through your training. And so just to say that I would encourage you to think about if that's something you're really interested in, at least continue to have CL on your radar. And like I said or rather, as was referenced at the beginning of the talk, I've included my email address in your program. Please reach out to me anytime regarding residency application, fellowship application, questions about CL or life in general, and I'm happy to be in touch.
Thank you so much, Dr. Zabinski. That was a great talk, very insightful into what CL psychiatry looks like. And thank you guys for being here and all your thoughtful questions.
Thank you all. Thanks for the messages. Yeah. Bye.
Bye.